Hello, everyone. Kids are also quiet. Happy.
My allergies are kicking my butt today, so I'm muted.
Oh no. Oh no, allergies. It is a very rainy, gray day in Chicago. You know, the normal fall. So happy end of Vet Tech Week. I'll extend it out till today. Why not? What did you guys do this week? Anything fun? Study? Yeah. Anything for any of you guys work? Did you guys do anything at work? Anything fun?
We did a corn maze.
That's cool. I love that.
Yeah, it was a lot of fun.
That's really awesome. I love that. That is the first that I've heard of doing that, but that's really cool.
Yeah. I
mean, I could do that where I live too, because it's funny. I say like I'm in Chicago, but like we have corn too. So that's really cool. Was there like money involved? And
no, we just split up in teams and raced who could get through it faster.
I'm like, was there money? Was there like other things involved in this? Like, but that's still really fun. Like, at least, you know, like get out of the hospital too, you know, just to do.
Yeah.
Something. That's really cool. Sometimes we need that. Anybody else? Anybody do anything extra for themselves this week? Guys.
My students made kits for Vet Tech Week, and we dropped them off at a bunch of local hospitals. So that was fun. It was a good community service project.
That's
but
awesome.
Everybody was like super, you know how busy everything is. Yeah. So when we were stopping in, one of my favorite ones, they're still curbside, so we went to drop off, and the person was talking to a customer, and then another customer came up, and she went to turn around and go inside with her clipboard, and I was like, hey, wait, just hang on a second, turn around. And she turned around like a little bit mad, you could kind of see, and then I handed her a baggie full of these cute little survival kits that we made, and I was like, happy Vet Tech Week. I was like, have a great week. And she's like, what? And I was like, happy Vet Tech Week, these are for you. And she just looked down for a second, and she was like, this is so nice. And she just turned around and walked inside. Like, it was really sweet. And it just kind of showed like how stressed everybody is. And, you know, good way to lighten the mood.
It's incredible. Like, I think that, like, in general, that that is really awesome. Number one, that you guys did that. Number two, that shows how stressed in general everyone really is in the culture that we are all in, and that like the act of kindness that just people could do of just a little thing just changes everybody just so much. Like, if we all just did one little thing, like that probably changed them so much.
Everybody had such a great reply. It was actually a lot of fun dropping them off, and then, you know, getting to see the reactions. And the students grabbed ones, we put together little packages for hospitals by their house, so they had the opportunity to drop them off, and just their experiences with the reactions was really, you know, it wasn't a huge fancy thing.
Right.
They were like these little survival kits with these cute little sayings with a couple little things in each one. We did it so we could make quantity, you know, to reach a lot of people, and it was just really cute.
Yeah.
It was a really feel good thing.
And it makes, you're right, it makes the students feel good because they see the reactions of those people, and then it makes those people feel good because you know what, they don't get anything, you know, they get the bad like reactions lately, in particular, versus like the recognition of like, hey, we see that it's Vet Tech Week. We see that you are going through a lot and you're working really hard, and here's a little survival kit, you know, that just, here you go. Like, we recognize you. That's pretty cool.
So it was so great to see them, and definitely something we'll continue doing because it was, you know, really meaningful.
Yeah, I think that's super awesome. You know, like it means extra, especially this year, I think. Like,
and I think for some of the clinics, I know a lot of clinics did recognize people and their staff in some way, but not every clinic does.
Yeah, absolutely.
So,
yeah, no, that's really awesome. Like, that was really, really awesome. Yeah, I think that was fantastic. And I think too, like, just like teaching your students just like what Vet Tech Week really is, and just like more and more about that, we do need to recognize not just, you know, we should be recognizing everybody in our field, like, and in any field, like, let's just recognize people here and there, you know, just like the hard work that they're doing, you know, and how hard is it just to say like, thanks for all your hard work that you're doing, you know.
Yeah, we handed them out to all staff. It was for all staff, even though specifically it was Vet Tech Week, just because everybody's super stressed.
Yeah,
we were gonna do donuts, you know, those also work.
Yeah, no, that's really awesome.
Thank you.
That's super great. I love that. Wonderful. So, I mean, I think it's important too, like, that during Vet Tech Appreciation Week, that you appreciate yourself during this time. So, you know, it's one thing to look for, you know, people to reach out to you and appreciate you, right? Like, we all want to be felt like we're appreciated and everything. But also look at yourself and be like, you know what, it's Vet Tech Appreciation Week, and I deserve to appreciate myself for what I'm doing. So that's why I said, like, did you guys do anything for yourselves this week? Did you stop for a second of studying, of working, of doing anything, and just, whether it's 30 minutes of like going out and having a cup of coffee, or, you know, like treating yourself to something, you know, like something that you really enjoy. If you want to go see a movie, if you want to go out to a nice dinner, or, you know, like do something for yourself, like treat yourself to something that's relaxing, like whatever, and just say like, it's Vet Tech Appreciation Week. I'm going to do something cool for myself. You know, you deserve that. You deserve to appreciate yourself. And we don't do that enough. We don't ever appreciate the things that we have accomplished in our field. Like, what makes you successful in life, right? So I have talked to other technicians out in the field, and I have said, do you feel successful? Do you consider yourself successful? You know, and they're like, I don't know, like, what is success really? Like, does it mean that you have to publish 14 books, or, you know, talk at 8,000 conferences, or whatever? Success is subjective, right? So you can be successful just by every day of what you do. So, you know, am I successful? Yeah, like, I have 2 wonderful kids. I have a husband who I love and care about. I have you guys who I absolutely adore, and I work really hard to be with you guys as much as I possibly can. And, you know, I I've been a surrogate, and that was a huge accomplishment. And, you know, I've done all of these great things, and I still want to accomplish things. So to me, and I've been in this great, amazing career, and I still want to do so much more. So to me, you know what, this week, I'm going to celebrate myself. And for you guys, the same thing. You've been to school, you've been working super hard, you've been doing all this stuff. You should celebrate yourselves. So that's success, right? And you're going to keep succeeding, even if, say, you know what, I failed my test once. That's okay. You know, some of you guys may have failed a couple times. That's okay. You're still working hard to get there. Failure is only when you stop trying, right? You're still trying, you're still doing it. So keep celebrating, celebrate your accomplishments and everything that you're doing. So take some time, put your stuff down, and enjoy yourself. Enjoy like what you're continuing to do, and go, you know what, I am going to continue to do what you do. When you stop doing stuff for yourself, that's when you start burning out. And then that's what pushes us out of the field, because we burn out and we don't actually do things for ourselves. So consider doing that. Consider doing some fun stuff for yourselves. Yes. So moving on to like what we can talk about today. Any questions on what we are currently working on? What did you guys work on this week? You have like, we were going over vaccines and stuff last week, right? Correct?
I think so, yeah.
Okay. So this week, we're doing emergency fever.
Speaking of emergency, I already have a question.
Oh boy.
But it's a simple question. It's a simple question.
Okay.
I feel like with like the spring and not the spring, the fall that's coming, you know, it's getting very wet. A lot of pet owners, they're reporting that like their animals are having like little rashes. It looks like little like yellow pimples. Could that be like a fungal infection?
Could be a lot of things.
Like it looks like a yellow, like little yellow things.
So one, it could be allergies, especially since there are spring allergies and there are fall allergies. So that could be one thing.
Mm-hmm.
It could be allergies, and then because of like itching and stuff, then it can turn into a bacterial infection. So that's another thing. Fungal is weird that it'd be fungal. However, especially if it's like a common thing, there is of course always fungal that it could end up being, but like there's always like fungal stuff, but usually if it's like a lot that you're seeing, it's a lot of, there's a ton of allergies. So I always say derm, bring them in, have them looked at, and then go from there. So I know we have talked about derm issues in one of the sessions like a ton when we were talking about Apoquel and Cytopoint, and everybody's just, it's like water at this point. People are just Apoquel and Cytopoint like crazy. So
what I find interesting is most of the cases that like, or like the reports I've been seeing, it's mostly inguinal.
yeah. And so that could be allergy related too, because if you're looking at it, if they are going to the bathroom, right? They're touching grass and all of that, and it could be inguinal as well. And then, so that's one. It also could be, depending on where they're going, there's also, and who knows, like if they're going on walks too, it also could be that there's some sort of like, I don't know if it's like poison ivy too, like depending on if they're going out somewhere, but that seems like a little bit of a stretch. So yeah, it just kind of depends, but without seeing it and without like knowing exactly, because you're in Canada, I don't know what you guys have. It's something that should be seen. So
The best part is when the owners freak out and they're like, all the clinics are closed. What do we do? And I'm like,
I know.
trying to think, I'm like, coconut oil temporarily, that could maybe soothe it. Is it something that's usually recommended? That people
I mean, for what I would say is obviously like keeping it really clean. If they absolutely have to, like they could try Benadryl and seeing if that helps clear it up, because at least you can know that like if it's an allergy related thing, they could do that to kind of rule it out. That's the really hard part, is right now they can't get into a vet's office. So and so it's like trial and error. But again, now we're like pushing the limit of like going, okay, what can we like tell them and not tell them, but at the same time we want to help them too. I'm not a huge fan of coconut oil because like especially in derm, because it I don't know, it's kind of like trial and error. I think coconut oil can sometimes be overused, but whatever. You could try to dry out the skin too, so like antibacterial soap, and just like kind of keeping it clean to try to dry it out, because if it's like moist, I guess, I don't know, of like dermatitis type of thing, but that's just some of the things until they can get in. So trying to make an appointment and then until they can get in type of thing.
So what type of, like, you're talking about antibacterial soap? I'm trying to think.
Yeah, just like a regular like Dawn dish soap type of thing.
Oh, okay.
Yeah, because it'll dry it out. Otherwise, like, I mean, obviously I would love to do like chlorhexidine, but not everybody has chlorhexidine. So just like, again, over the counter type of thing, So, but, trying to do whatever you can to rule out things at home until you can get in whatever, sometimes clinics are like 2 or 3 weeks out. So that's the hard part.
Yeah.
But I know it's hard. So, okay. So, emergency medicine. Anyone work emergency in the group? Or have worked emergency? Or anyone want to? I always love
Per
that.
diem.
You what? I'm sorry?
I per diem.
Oh, okay.
I did my internship many, many years ago, and then one of my former students dragged me back. And so
Nice.
I don't commit to it full time, but I do per diem shifts. And I honestly went back to working most holidays.
Okay.
Just
Great.
because they're busy and you get to see some really interesting cases.
Yeah, absolutely. Absolutely. Yeah, that was my first passion, I'll say, when I was in my 20s. So I worked emergency for 10 years. And I loved it. I worked on my VTS in emergency critical care. And then they dragged me into medical oncology. So, and then that was like my second passion. And then I moved on from there into like education and stuff. So, but you see a ton of different things, like random things, right? So it's just like really exciting and fun, and you never know what's going to come in. And I cannot imagine what caseload is like right now. Like, just, I mean, I've seen, because I've been able to travel around to different practices. And so I've been to specialty clinics now and seen like literally a 9-hour wait. And them just like lining up charts and just telling owners like, go home and we'll call you when we're able to, like, they'll leave the patients there, you know, and then they're like, okay, you can just go home and we'll call you when we were able to put you in a room. And I'm like, that's just
Right. And unfortunately,
crazy.
because GPs are so overwhelmed as well, we're like even emergency is seeing some general practice stuff like ear infections
yeah,
because they can't get in anywhere. And yes, that would be a very long wait considering that we have to take the emergencies first. But
Right.
yeah, there's definitely some great cases there. And I too got hooked on emergency medicine doing my internship when I was in tech school. I took one of my internship for my clinical hours in emergency.
Right.
And after that, I was like, this is awesome.
Yeah. I mean, and you get so much experience. That's the thing too, like to work on your clinical aspects of things, like your skills and stuff too. So it's really great, like, especially when you get out of school, because you're like, okay, you know, like you don't get as much time to work on like placing catheters and drawing blood and all of that when you're in school, right? So like you get out and you're like, oh, this is perfect for me to be able to work on this stuff and see all these cases. So you are hooked, right? It's exhausting at times.
You get to really think on your feet, practice a lot of skills that you don't always see in GP. And
yeah,
I mean, usually there's also a good bunch of techs that, you know, are seasoned there as well to learn from. So it's a great learning environment, even though sometimes people are afraid to put their foot in the door because they may not be as confident in their skills.
Right.
It is a really great place a lot of times to learn and pick up those skills that you're a little unsure of.
Absolutely. Yeah. No, it's really anyone who really wants to do pretty much anything skill wise or critical thinking wise. And if you have other specialties within that practice, it's great too, because you can really like kind of, you know, hook on to the other specialties here and there and like kind of like being a fly on the wall too and be like, what are you guys doing in there, you know, or whatever. So it's kind of nice to be able to go to get in there, you know, and to see all of those things. So you know, I think it's great for like newer technicians to do those things and get that experience. And then, you know, and then even if you want to go back into general practice, you still have that experience to bring back to general practice later, you know, or back and forth, or do emergency fill in like you are doing, you know, here and there. So it's awesome to have all these additional experiences. So awesome. So emergency medicine is definitely, gosh, it's so different, right? Because you said you're seeing ear infections, you're, you know, seeing all these weird things. Now, ear infection, is that going to be an emergency per se? Do we consider that something that's necessarily an emergency? Not necessarily all the time, right? But at the same time, more of an urgent care, maybe, right? Like we may consider that something an urgent care. So because of the fact that it's uncomfortable, right? Like, would you guys go to urgent care if you had a really bad earache? Or your kid had an earache?
Yeah. Because they're screaming and
right,
because you don't know what they have, and you're like, I just want to fix this. So you stop screaming and scratching, and it just diminishes the stress on everybody when they know what their kid has.
Yeah, because they're uncomfortable and whatever. So like it's understandable that an owner would bring them in. However, people that have worked in emergency, like it's an ear infection, right? So like we do understand, but at the same time, they're so busy and we're like, oh my gosh, it's an ear infection. Like it's down on the list of like the worries of, hey, we're dealing with like a bloat and a hemoabdomen, like really critical, and then an ear infection, right? Or an anal gland abscess, right?
But what if the ear infection turns into an otitis? Is that how you say that?
Otitis?
Yeah.
That's the same thing.
Yeah. Oh, okay.
Yeah.
Or like the perforation of like the
So like an eardrum, like rupture.
yeah.
And
yeah.
it could be, it absolutely could be. But again, life-threatening? No, right? So
No.
like, but it's still, again, painful. So like, we still need to address it. And I think that that's important for us to realize an emergency is that it's an emergency to that owner, you know? And so we do want to be cognizant of like, hey, to this owner, it's an emergency. And so we'll get to them, right? We will take care of them and care for their patient. But at the same time, we do need to communicate with the owner well that we do have other patients currently that are very critical and that we do need to care for first before their patients. So how do we communicate with them? Sometimes poorly.
Delicately.
Yeah, right. Yeah, very delicately.
You have to be honest, and it's one of the things I like about Veg when they're bringing their clients to the back to show them why their pet may not be assessed as quickly and what it actually looks like going on in the back, and be able to communicate that to clients. It's not that we don't want to help you, and it's not that your pet isn't important. It's just that there's only so many people and so many hours, and we will get there. Like, we're all working very hard. Nobody's sitting around, and nobody's, you know, taking time off, and most of us aren't even eating.
Yeah.
You know?
Right,
I feel like
right.
there should be a commercial that's made for that, like on the TV, on the radio, because that seems like a universal problem, like as much in Canada as it is in the US.
Yeah.
And as probably it is in other countries as well. Like, it's just owners don't realize how hard techs and vets are working and all the veterinary staff. And
well, so Lisa, you said, so let's talk about, so everyone, have you guys heard of Veterinary Emergency Group?
No, actually.
Okay. Well, it's in the States. So, so what, Lisa, tell us what Veg does with.
So Veg is an emergency and critical care facility, and one of the movements that they've made is to actually promote a living wage for technicians, which is cool. That's one of the things I really like about them. But the other big piece of their services is that they allow clients to come back with their pet through every step of the way. So say you are fielding a hit by car, right? You have a hit by car come in, the clients are allowed to come in, and they're allowed to be there during the general assessment, while we're placing IV catheters, while you're taking x-rays. Obviously, they're not in the room during that time, but just to see the processes of what's happening. And their foundational belief is that allowing clients to see what we do conveys the importance of our job, what the different professionals do, but also our pricing. You know, when you see it in action, it really does show you why the value is there, and that no, we're not overcharging you. And yes, we are working hard, and we're sorry about the 4 or 5 hour delay, but we had, you know, a case that needed CPR that took priority. And I think that it's nice for the clients to be able to see what we're doing. And I think client communication is really important. And I know some people love curbside and love not having clients inside. This is the total opposite of that.
Yeah. And
I'm wondering though, is there like a waiting area where there's actually like a sit room where there's like a transparent window where owners can see, or are they visibly, like, there's chairs against the wall with a line? It's like, please do not cross that line. I'm curious.
I haven't worked in the facility, but I know a bunch of people that do, and for a good portion of it, they're alongside their pet.
Yep.
From my understanding.
Yeah.
Wow.
No,
Cool.
Absolutely. So yeah, they're able to be literally with their pet. They also, like, for surgery purposes, they're not allowed to be in surgery, but they do have a viewing area where they're able to view surgery as well. So which is really great, right? So again, like Lisa said, this is so amazing because just like in our last session that I was just in, we were talking in dentistry, how it's really hard to convey like the pricing for dentistry, right? Because dentistry seems to owners a lot of times to be really expensive. Like, what are they getting for dentistry, right? Wouldn't this be fantastic if we had the same principle for dentistry, that they get to see what actually goes into a whole dental procedure? Obviously, VEG doesn't do dentistry because it's emergency critical care. But if we had this concept in other facilities, they could see that whole process, right? And so they would be like, wow, this is all that goes into it. This is what a technician does. This is how they monitor. This is how they do everything for my pet. And then the owner can be with their pet and see everything, and they get it, right? They get the whole process. Now, in human medicine, we get to be with our I almost said patients. We get to be with our family members for the majority of the process, right? Of everything too. So we could do that for in veterinary medicine, you know, like what are some of the tie-ups on our end of why we wouldn't do it? Why would some people, what makes people nervous about doing that?
I feel like sometimes,
or doesn't?
I feel like sometimes you'd be like stepping on people's feet all the time. Like they'd be under your feet all the time.
Yeah.
Liability.
What liability?
You know, people could be afraid of what they might see or perceive. But again, the client communication is the reason they bring them back, so that you can communicate what they're seeing. But some people are afraid of that, and you know, and that's why I think that some people are uncomfortable with the idea of it. But I think it's fantastic.
I think it's about client communication. You can't be afraid to communicate certain things, you know. You have to be able to just be bold and say, you know, sir or ma'am, can you please just take a step back really quick as we do this, you know, or like, we're just going to hold your pet really quick or whatever, you know, for this purpose or whatever. Like, we can't be afraid to just say those things at the present moment or whatever, so that there isn't that liability aspect, or just communicate like exactly what we're doing at that moment, you know, or we're doing this procedure, and explaining those procedures, you know, so that they understand why we're doing those things during that moment, so that they're like, oh, okay, and not like freaking out, like, I can't believe you just did that to my animal, you know, like, we did this because, you know, X, Y, and Z. So it's all about client education as well while you're doing those things. Yes, it can be hard in the spur of the moment, but even afterwards say, hi, I know that might have been scary that we did that, but I just want to explain why we did it, you know?
Right. And the other big one is always my favorite, when people go into the field and they don't want the pet owners in the back because they went into this field because they like pets more than people.
Right. And that's really funny too. When I was teaching, I would say, hey, why did you go into the field? And they're like, oh, because I hate people. And I was like, well, I think you should rethink that, because you're going to be dealing with a lot of people and in a very emotional state. So you're going to have to like know how to talk to people really, really well, you know? So it's really important to be able to relate to people as well, and just be empathetic. That's the biggest part, is learning how to be empathetic and put yourself in their shoes at that present moment. And so that's what empathy means, is to be able to put yourself exactly where they are at that present moment, and so that you can look at them and be like, oh my gosh, that person's freaking out right now. How can I help them? So during that entire process, like, you take that animal back, and that's what VEG did. They said, okay, these people are freaking out. Like, we're taking these animals away. So how can we help these clients feel better about us, like, caring for their pets? Can we bring them in back so that they can see what we're doing. And then maybe they'll understand why we have to charge what we charge. And can we help them feel better about the fact that we're caring for their pets the way that we do? And so they're like, let's try it out and see if it works. So I think it has really helped in that aspect. And so they're trying to start this movement and see, hey, not only can we do this, but can other people also do this as well? So we'll see how it goes.
And like from a technician point, I think one of the fears is that technicians don't want to have owners breathing down their neck and judging how they're doing the work. Like I remember reading a horror story where there was a owner that insisted on holding his dog. I think it was a pug, and like they clearly said, no, sorry sir, you can't do this because this is our policy. And so the owner started like questioning like the tech and just trying to make her admit that she's doing a bad job, essentially. And so when the veterinarian confronted like the owner about it, because the tech went and talked to her boss, he clearly admitted, oh yeah, like I was emotionally abusing your employee because I went to like see why she was doing it and make sure she knew her stuff. Like, why do people do that?
I mean, I think that too, like, again, it's all about communication too. So if rather than, saying, well, how about we just have, like taking control of that communication aspect of it and say, well, I'm just going to have this person hold, and how about you just like pet his head while we're doing it, So like, changing up that communication, he's still able to touch his dog, right, during that, he's still able to be involved. Like, I think owners want to be involved somehow.
Yeah.
In that case, like he wants to still be involved, so involve him. Have him give the animal treats during that time or something like that, right? So if they can eat at that time, sometimes they're not able to eat, but like have him still be involved, but still take control over it. So because say it's a pug nail trim, we all know how pug nail trims go, right? We don't want that to happen. So yeah, like, it's always about like communication, and that we have to take back that control, so that we keep it a safe environment always. So but I know that like I've done my procedures like blood draws and nail trims and doing vaccines and, or injections or anything like that in front of owners. I have no problem doing that. And I think it's just because of confidence and being able to educate owners at the exact same time too. Like I'm telling them exactly what I'm doing all the time. So I feel like I'm doing it just like I would do like a TPR in an exam room with an owner, because I'm confident with what I'm doing and I still want to educate them on exactly what I'm doing at the same time. So I'm not like, oh, I'm poking your animal for the fun of it, or I'm not confident in my skill set too, So, and say we miss a vein, it's okay. We all miss veins and stuff. We just go back and try again. I think, it's the same thing. Like if a nurse misses your vein or whatever, you just try again. Owners understand. Okay, so back to we have in our emergency practice, we usually have a crash cart, right? What would we want in our emergency crash cart?
Your emergency drugs?
Ooh, yeah. So let's see. Crash
Your naval drugs?
cart. Okay, so let's start with drawer 1. So let's start with drawer 1. So we'll drawer 2. Okay, so we'll have drawer 1. Drawer 2 is going to have drugs in it. So in our drawer 1, we're going to want something else than drugs.
Like supplies, like catheters and stuff like that.
Catheters come. Usually our drawer 1 is gonna sound okay. So I'm gonna put our catheters down here. Drawer 3, supplies like catheters. I'll put syringes, right?
Yeah.
What else we have? Catheters, syringes, maybe like tape, like all that stuff, right? Etc.
Yeah.
What about drawer? Oh, drawer 4. Yeah, like usually like 4 drawers or something to this extent, right? In your crash cart. And we'll talk about, you said naval drugs. We'll talk about naval in a second. What's in drawer 1?
Endotracheal tubes.
Yes, ET tubes. So typically you can't have every size ET tube, right? Like that'd be just too much stuff. I mean, unless you have a really big crash cart. So what do you do in this case? Like, what if you have an animal that comes in and say you just keep like in your crash cart, like cats are usually like a size 4, right? Like you keep like a 4, a 6, an 8, maybe you keep in there like a 4, 6, 7, 8, and a 10. So you just do that, right? Just like certain sizes.
You could just have masks in there as well.
A mask?
Yes. Just for like oxygen.
Oh, and a mask. Okay. And a mask. Just to oxygenate them. Yes, good. But we have ET tubes so that we can ideally, put a ET tube in them if we needed to, right? So, so the idea behind it is, yeah, you want to try to put an ET tube in them that's like an appropriate size, right? Especially like if we were doing anesthesia, you want like an appropriate size ET tube in them, correct? Like that's gonna fit them perfectly. But in the case of like doing CPR, you're not gonna like size them up perfectly when you're intubating them, right? Because it's gonna take too long to be able to do that. You want to just find like the closest ET tube size that you think is going to fit them and intubate them as fast as possible, right? And then once we actually bring them back, we can always switch out the ET tube to the appropriate size if we need to keep them intubated, right? We just need to be able to get an actual like airway in them at that present moment. So say you have, like a beagle that comes in that needs to be, well, I shouldn't use a beagle because beagles are usually like a 7, but like maybe we have like a border collie that comes in and it needs to be intubated and you have a size 7, right? You don't have an 8 or you don't have like a 7.5. It needs a 7.5. You have a 7 in there. And so you intubate it with a 7. And it's not the quite appropriate size, but you at least have an ET tube in there. And so then after it comes back and it's stable, you can always change it out to a 7.5 or whatever. So that's the ideal. And then so with your ET tubes, you're going to have your tie already on there on these ET tubes. So it's already going to have the tie on there. And then ideally, you know how you have like the bulb on your ET tube to inflate the cuffs? You'll have that 12 cc syringe already attached to the bulb so that you can inflate the cuff. So it's like really easy to like inflate and be ready in your ET tube. So you want to have that stuff already available. And then also a laryngoscope should always be in your crash cart and be ready to go. And it should be functional, right? We want to have a light on it. Now, in our drugs, so what drugs do we really, really want in our crash cart? We said navel, but what is that?
Noxolone, atropine, vasosuppression, epinephrine, and lidocaine.
Wow, great. So yeah, naloxone, atropine, vasopressin. She's like, I got this. Epinephrine.
I have my notes on it.
Oh.
I was just doing notes on it the other day, so I had them sitting in front of me in my notebook. So when you asked that, I already had.
You're like, I got it. Perfect. So epinephrine and lidocaine. Awesome. So that's our navel. So that's where we get navel from right here. Okay. So what is so like fantastic about these navel drugs? What makes them special?
You can put them down the ET tube.
Right. So these are the drugs that if you needed to, you put them down the ET tube. Okay. So if we put these down the ET tube though, what do we have to do with the dosing? So
We have to
Double the dose.
okay, wait.
Oh yeah,
Sorry.
double the dose for ET tube.
Yeah, double the dose.
All right, perfect. Yeah, so we double the dose. Good. I'm like, everybody's talking at once. Yeah, so we just double that dose, okay? So if you put it down the ET tube, there's a couple different ways that people have done it. So obviously you can take your syringe and squirt it down there and then just give like a couple breaths with like your ambu bag. This is the drawer for is like ambu bag. And then some people put like, oh, I should put like blades in here and stuff too. Ambu bags, sometimes people put like a minor surgery pack. Just depends on certain places. And then some other people will also, like if you do ET tube dose, some other places will sometimes dilute this with some saline and put it down the ET tube. I have never done it that way because I am like, oh, that makes me a little nervous with a bunch of saline going down there. But it just kind of depends on like the place that you work at. So now, what about if you do any of these doses intracardiac? What is the dose?
That would be like your atropine that you'd use.
Or I should say dosage.
Is it half the dose?
Ooh, good guess. One-fifth.
How would you calculate that?
You just divide it by a fifth. Divided by 5.
5 Okay, cool.
Now, will you probably ever see anyone do that? I don't know. In the spur of the moment. Your doctors are probably like, just give me the drugs and I'll do an IC stick, right? Like the intracardiac is like your kind of your last resort, right? I mean, maybe not last resort. It's not your like number one resort. Why is that?
Because you don't want to cause trauma to the heart.
Yeah, right. Absolutely. Yeah, it's not something that we're like, yeah, let's just stab the heart and you know, put drugs into it, right? We'd rather find other ways of giving medication than just sticking the heart. So if we can't get medication that way, then we'll go ahead and do it, but we're not going to give it that way if we don't have to. So but yes, that is the dosing for it. So in the cases where we actually have to do that, their mind isn't usually like, okay, let me do a quick calculation. They're just like, give me the drugs and I'll give it that way. But ideally, it is a fifth of that dose. So sometimes we do add some other drugs to our drug drawer there that you may see. So because we do see some other emergencies that come in that are not doing well, right? So what are some other drugs that you may see in this drawer?
Your antiemetics.
That's probably not, so antiemetic is an emergency case, but is not like a crashing case where you need a crash box, right, for that. So what is like an emergency one where you'd have to like go and get something really fast to keep it in a crash cart?
Are we talking about like a cardiac crash or like a poisoning or like?
Yeah, sometimes you may see like for cardiac stuff, you would probably have this in there.
So dexmedetomidine would maybe be one.
Yeah, we don't know.
Soap, if you have those intense cat reactions because they have like those flea collars that they're not supposed to have on.
Okay, so I mean, that just obviously like, yeah, if you have like your Dawn dish soap for that, we just keep that. Obviously we're not gonna keep that in crash cart, but and then we also give sometimes like atropine for that. But we will keep calcium gluconate. What do you use calcium gluconate for? On emergencies. So an interesting
Gluconate.
these are interesting emergencies.
Would that be like for a cardiac issue or like a poisoning issue?
Neither. Reproduction.
Oh, emergency C-section?
Not C-section. So there's two for
Like
reproduction.
dystocia?
Dystocia, yes.
Dystocia.
And
Hypocalcemia.
yes, very good. So your eclampsia, right? So very good. So dystocia. So anyone see dystocias ever?
French bulldogs.
Yes, our French bulldogs. Oh my gosh, French bulldogs. There's French bulldogs everywhere. Like everyone has gotten a French bulldog, I feel like. what is the deal? Oh, I mean, they're cute, but come on now. So dystocias come in, and if a dystocia comes in, what do we first give them?
Oxytocin?
Oxytocin, right? That's our first drug. Yes. But then oxytocin works better if we also give calcium gluconate. So it's calcium gluconate augments, so meaning that it makes oxytocin work better, right? So that's why we have calcium gluconate. That's one reason why we have calcium gluconate there. So you can also have oxytocin in your crash cart too, but you don't have to. But calcium gluconate really is in your crash cart for hypocalcemia or eclampsia, because eclamptic animals that come in, how do they look when they come in typically? What do they look like? How do they present usually? Do they look like, how do they
Maybe
appear?
lethargic, I'm guessing. Maybe exhausted.
They're
Yeah.
stiff.
Stiff, yes, they're stiff.
They get the back legs sometimes are very like the last one that presented, I mean, she looked like a mill dog anyway, honestly, but aside from like the lethargy and she was very stiff, very stiff.
Yeah. And then sometimes they'll also present like they almost look like they're seizing because they're like tremoring. Right. So so you'll see them with tremors. And then because of the tremors, but you're going to also potentially have a fever too, like a really high fever. So with the calcium gluconate, we have to give that to them to help with the tremors and then also being so stiff. So, and it subsides pretty quickly because of that. So you do have to give calcium gluconate pretty slow, like over like 20 minutes or so. And then you also have to have an ECG on them as you're giving it, because they can have bradycardia if you give it too quickly. So you just have to be careful. So that's like kind of the concern with that. But yes, this is why we keep it in the crash cart, just so that we can make them feel better. So with those guys with eclampsia, sorry, my cat is like rubbing on my computer, so I have to like push him away and he's knocking my laptop over. With eclampsia, what is our recommendation then for those guys afterwards? I should say, why are they eclamptic to begin with?
The lack of calcium.
Okay.
Giving their calcium to their babies that they're trying to give birth to.
Okay, so they had already given birth already. Like this is probably like usually happens 4 weeks after they've had their puppies or kittens. So
3, 4, 5 weeks or days?
Weeks after.
Weeks.
Yeah. So, but you're right. All their calcium has been sucked and just given away, essentially. That's gone. So why is this? Like, what happened? Usually, what has happened?
They're nursing puppies.
Yeah, they were nursing, right? And so those little parasites, as I call them, that's what I called my children too.
They suck the calcium out of the mama.
Exactly. They just like took all their calcium away, right? And so a lot of times this happens too because the nutrition ahead of time, like when she was pregnant, she didn't have the best nutrition, right? She didn't maybe eat the proper amount or kitten food or puppy food to get that calcium, right? So they sucked all the calcium out of her ahead of time too while they were growing, because remember, they need that calcium to grow their bones on the inside as well. So think of them as parasite, right? They're sucking all the nutrients out of her during that time, and she's not getting that appropriate amount of calcium. Just like when we're pregnant and we need to get calcium for our, you know, I almost said puppy or kitten, our baby. If we don't, they just suck the calcium that we have stored in our body. So then we're like deprived of our own calcium. So she is too. So she then becomes eclamptic. So how do we then, so we have treated her eclampsia at that present moment, but she needs to then continue to build up that calcium long term, right? So how do we treat that to go home? Like, can she just go home and start nursing again?
Well, she's gonna lose that calcium again. So puppies would have to be on formula, I'm guessing.
Okay. Right. Or if they're old enough, right? Say they're like 4 or 5 weeks, we could probably wean them at this point, or start weaning them. But you're right, like no more mom, you know. And then how do we treat her? What does she need to be on from then? Because we need to
Calcium.
We need to give her calcium.
Yeah.
So what kind of calcium do we give her?
The calcium gluconate.
Okay. So, but we can't have the owner give calcium gluconate at home, right? They can't give an injection. So like, what is the easiest form of calcium that they can give her?
Broccolis. Maybe not, but I know broccolis have a lot.
Yes,
of
because like, but that she'd have to eat like a ton of broccoli, right? So like,
yeah.
What's a better form that's gonna?
Like a calcium supplement then?
Yes. It's a calcium carbonate. So you guys know this form. It's over the counter. You can pretty much buy it anywhere. You take it when you have like heartburn.
Tums?
Yeah, Tums.
What? You can give Tums to your dog? Or
Yeah.
is that like the brand name?
But I mean, that's the brand name of it. Yeah.
So Tums is the brand name of calcium gluconate.
Calcium carbonate.
Calcium carbonate. Okay.
Yeah.
Huh. No. And like as far as dosing, like I'm always curious. That's the main thing. Like from
there's a dose for it. You just have to look it up.
Okay.
It's probably in Plum somewhere.
Plum. Right. Done with that.
So yeah, that's the easiest way of doing it. So, which is great because it's super cheap then for the owner. All right. So that's our eclamptic one. So let's talk about another emergency that we see a lot during the fall too. I always love. And with our cat, since I have my cat sitting right next to me, and he's a male, a neutered male, and he's about, I don't know, how old are you, Basil? He's like 2.5. So a blocked cat, right? I'm like, here, I'll give you his signalment, and guess what I'm thinking of? All right. So urinary obstruction, right? So how does this happen? Urinary obstructed cat.
Calculus in the urethra?
Okay, so that's one way it can happen, right? They could have like crystals or something to that nature. Yes, but not always.
Or they're eating a diet that does not have enough like fluid in it. So they're eating very high sodium food.
Okay,
Mhm.
so yeah, they could potentially not be getting enough hydration from food or just like enough water in their diet, right? What is just some other reasons why they could be blocked?
So I know this is probably not the answer that you're looking for, but we had a block tom come in to our clinic this week, and it had some sort of like mucus plug, like it
Yes.
was like clay type.
Yeah. It's
Yeah.
so gross, right?
That was really gross.
I mean, so you usually see that actually. So you see this mucus plug and it could be filled with anything like it could be crystals. It could be just like cells in general, like of cats, just like cats in general, whatever. But honestly, the biggest reason is just inflammation. And so, yeah, I mean, it's crazy. So, and so sometimes like cats are weird, like, stress can cause them to start having issues with like urinary stuff, so it really, you never know. So, and so there are some cats that they're more prone to having urinary issues than others. And so, they have to be on special diets. And so depending on what those diets are, like, that's what we have to recommend. So, and how do we know what those diets may be, right? So it's based on the protein content and all of that. So I'm not going to get too much into diets because we'll sit here all day. But so our treatment for that, though, because we're talking about emergency, is what is the emergency at that point? Like when they come in, what is the emergency?
They can't pee. Until the
Okay.
bladder gets full.
But what is the life-threatening emergency?
The bladder will explode.
Okay, that's what most people think, right? But that's not the life-threatening emergency.
Is it because toxins are building up?
Yes, very
Toxins.
good. Yeah, the life-threatening emergency is that they can't pee, but they can't excrete out what? They're building up what?
All the
One thing in particular.
urine.
No.
Uric acid?
So when you have a black cat, we're worried about potassium building up.
Potassium buildup?
Mm-hmm. And so because potassium can't be excreted at this point, right? And so at that point, if too much potassium builds up, then it can affect your heart. And so this is why we say, oh my gosh, if you have a cat that's blocked, they can die because your potassium builds up too much. It starts creating arrhythmias to the heart, and eventually too much potassium that builds up will eventually stop the heart, right?
Correct. I've never thought of that.
So just like if you give potassium chloride, like too much potassium chloride, you will kill your patient, right? That's exactly the same thing that will happen in a block cat. It will naturally kill your patient, right? So it's not that like your black cat will die from, your black cat will eventually die because of a uroabdomen and blah, blah, blah. Yes, but your cat will first die from potassium building up. So your first part of the emergency is to address the potassium. So when you have them come in and you feel that rock hard bladder, right? Yeah, we want to make them feel comfortable, right? Of getting that urine off of the bladder, right? That's absolutely 100% uncomfortable, not fun. I can't imagine what that feels like. Like we've all been in situations where we're like, oh my gosh, I had to pee so bad, right? Like not fun and uncomfortable. I can't imagine what that feels like. But at the same time, when you take an electrolyte blood draw, like you're taking their electrolytes and you see that, you know, our normal potassium is like 4.0 and their potassium is like 8, you're like, holy mother, we got to do something, right? So how do we fix that other than unblocking them at that present moment? Because sometimes you can't unblock them right then and there, and you know, like it's not gonna fix it at that present moment because you gotta get the supplies and whatever. What are some things that we can do? Or what are some things that you've seen?
Could you give some mannitol because it's an osmotic diuretic?
Oh, you're so close and good. Very, very. You're on the right path. You're on the right path.
Got to give some diuretic of some sort.
Gotta get, yes.
Can you pass the urinary catheter?
Yes, we will pass the urinary catheter, but right before that, like you're getting your supplies, right? So, but we're going to give something to them to also help get this done faster within the body.
Potassium citrate, which is a urine alkalinizing agent. Wait, no, your body has too much potassium. Never mind.
Yep. So there are two things that we are gonna give.
Are we gonna give prazosin?
What's that?
It's prazosin, the like urethral sphincter medication that kind of like
Oh,
relaxes,
okay.
you know, the urethra.
Yeah, I mean, you can do that. That's not going to help with your potassium, but yeah, you can do that. Absolutely. So what are we going to give though to help with our potassium though, to like decrease our potassium? Anyone? No?
We said mannitol earlier. You said you were close. So
What's another diuretic that we can give? So we're going to give some insulin and dextrose.
So some IV fluid.
So we're giving some insulin and some dextrose to pull out some of that potassium.
How does that work?
So in the same sense of being the diuretic, right?
So your insulin is the diuretic?
No, dextrose.
Oh. I'm still wondering, like your insulin, how does that?
And then the insulin augments it as well.
So the insulin increases the diuretic effect?
Mm-hmm.
No.
So it's going to help pull out some of that potassium. So if you see your doctor giving that to your blocked cat, then you'll know why that they're doing that.
So that would be the first thing to do before even like.
Yeah, so they'll typically do that like as they're like right before they are unblocking them per se, you know, so it's like a combination of treatment of what
So
they're
how-
going to do, especially when their potassium's that high. Like if it's not as high, they'll probably just unblock them. But if it's pretty high, they'll do both.
So how would you block them? Is it just like a urinary catheter that they use?
Yeah. So anyone, okay, so who was the person who had the recent unblocking of their cat with a mucus plug?
That was me.
Okay, great. So how did you guys unblock your cat?
So we basically sedated him a little bit, and then we just passed the urinary catheter and the plug came out.
Okay. Did you guys leave that catheter in for a certain time, or did you just like unblock him and flush it out really well? And
Yeah, so we just unblocked him, expressed his bladder, and then flushed him out, and then he recovered well.
okay, and he went home and still doing well?
Yep.
Okay, awesome. So yeah, it kind of just depends like on each patient, like how long they've been blocked to and stuff like that. Like, so in emergency like that, I've worked, usually we've kept them in ICU for at least a day or so, and then kept their urinary catheter in. So we'll use like what's called a Tomcat catheter, right? So they're like shorter catheters that you place, and they're made of polypropylene. So they're stiffer catheters. And so some doctors like the closed end ones, so they have like the holes on the sides, and some like the open end ones, so there's like the hole at the bottom. And then what you're going to do is feed the catheter in while you're pulsating fluid into it, so you can kind of flush through the urethra slowly, to kind of break up that mucus plug that's there, right? So that's why they can't urinate, is because they have a mucus plug, usually that's sitting in there, that's built up over time. So you just kind of work at it and slowly, so that you don't tear that urethra, because that would be very bad. And then you go ahead and slowly feed that through. Now, pushing that Tomcat catheter in, you really don't want to keep the Tomcat catheter in because it's very uncomfortable. I can't imagine having the Tomcat catheter in and leaving it. After you feed that in, you can place a more comfortable catheter afterwards. So there are a couple different options. So the one option is most people will use like a red rubber catheter. So everyone know what a red rubber catheter is for the most part?
Yes.
Okay. So yeah, you can use like a red rubber catheter. Most people use like a 3.5 French or a 5 French in cats. And then they just pre-measure like how far it goes to the bladder, and then mark it so that they can suture it in. Another catheter that I really like is called, I know it has a really horrible, like weird term. It's called a slippery Sam catheter. And so those are like made specifically for cats. And so they just measure all the way to the bladder anyway. So you just place those, and they're actually like really pliable, and they have a stylet in there, so they're really comfortable. And then you just suture it in. And so yeah, you could do either of those. And so then you hook those up to a fluid line, and then an empty bag, like an empty sterile bag, so that you can collect the urine, and then that way you can measure how much urine they're producing over a certain period of time. Why would you want to do that? Why would you want to measure how much urine they're like producing?
To make sure you unblocked your cat properly and there's no problems as far as peeing or anything.
Okay. Yeah, so that they are truly unblocked, right? That they're not blocked again, right? And then why else? if they're staying in the hospital, right? Like they're probably going to be on fluids, yes.
Mhm.
So why would we want to measure their urine?
To know if they're actually processing the fluids that we're giving them.
Okay. So what does that mean? What is that called?
Dialysis? No.
So our urine output.
Yes.
Okay. So like what's our normal urine output?
That'd be 1 to 2 milliliters per kilogram per hour.
Good. So urine output. 1 to 2 milliliters per kilogram per hour. Good. So yeah, especially when we have blocked cats or anyone with a urinary catheter, especially, we definitely need to be measuring their urine output. Typically, we would do it at least every 4 hours to make sure that they're producing enough urine, right? And so if we have them on fluids and their urine output is not high enough, right? That means that we need to turn up their fluids, right? Like they're dehydrated, essentially. Yeah.
Yeah.
If they're producing too much fluids, we need to turn down their fluids, right? They're overproducing urine. So we're overhydrating them. So that's how we determine like their hydration too. Another thing we do too is, or should do, right, is we need to look at how they're concentrating their urine. Yeah. So how do we do that?
Use a refractometer.
Yeah, look at your refractometer, right? So what is that? What is that called? What are you looking at?
Specific gravity.
Yeah, your specific gravity, right? So what if your specific gravity is like 1008? What does that mean?
Too high? I don't
Oh,
know. I'm not sure.
okay.
That's
Anyone?
too low, right?
Yeah, that's low, right? Like that's like almost water, right? We have some kidney issues. So what would you say like our specific gravity should be, just roughly?
Shouldn't it be like 10, 20?
Yeah, like 10, 20 would be awesome, you know? Yeah. Great. Awesome. So ideally we would have our patients for those guys kind of treated that way. So, and then we'll get, of course, a urinalysis going on them, you know, take a look at what's going on, whether, hey, do they have a urinary tract infection? Do they have crystals going on in their urine? Like what's going on in the urine so that we can treat them accordingly, right? So, you know, if it is crystals, then we can put them on an appropriate diet. If it's not crystals and it's just a, you know, a UTI that formed this bacterial plug and whatever, then we'll treat them for that. So it's not that, oh my gosh, every single, you know, blocked cat needs to be on CD food. It's not like, you know, we don't treat everyone the same. So it just kind of depends. Now,
What
let's
about
see.
urinary infections in females? Like let's say dogs.
Okay.
Something that's common in like spayed female dogs.
So it doesn't necessarily mean, okay, so it's spayed female dogs. I wouldn't say that that's like a common thing that you're going to see per se. I think that, sure, like there's urinary infections in any dogs in male or female dogs. It doesn't have to be spayed or neutered. I'd say that probably maybe because they're like closer to the ground or whatever, just the way that maybe some dogs urinate, that they might just have an infection. Also, like the certain anatomy of some female dogs sometimes can play a part, like just if the way that their vulva is formed can sometimes cause them to get some more infections than other dogs. So like if they have a recessed vulva or whatever, that can sometimes play a part. But it doesn't necessarily mean that it's because they're like spayed or not spayed. So it just kind of depends.
How could owners prevent like their animals from having urinary infection? Is there any sort of prevention they can do?
Oh gosh. I mean, I don't know that there's like a big sign of prevention. I think the biggest thing is like making sure that if they see signs of them urinating a little bit more frequently, I think that if like causing it to continue to become worse and worse is one thing too, you know, like I don't know that like not waiting to the last minute of it getting worse and worse is maybe one thing, but I don't know that there's a way that it, you know,
To prevent it, it's just
to
kind of deal
prevent
with it
per
when it happens.
se. Yeah. And I know that there are some animals that just get more and more urinary tract infections than others. Like it just happens, but I don't know that there's a way of preventing those things. So, and I think too, like we just have to pay attention to our animals and know their habits too, which can be sometimes hard when we let them outside in the backyard versus like walking them or whatever, but just being aware of what they're doing and that kind of thing too. So, okay.
Could it have an impact on the amount of grooming that they're doing?
Yes, absolutely.
Okay.
Yeah. And also that's another thing too, I guess for prevention wise is making sure to keep them clean. So if they are not getting them groomed regularly and stuff like that, that's one thing, you know, like if they are a long-haired dog and they're not being like kept clean in those areas, like that's one thing I would say, just to make sure that they are like kept short and not being matted and all of that. That's probably a big thing. Okay, so let's move on to another emergency. What is one thing that we see a lot? Oh, let's talk about bloats. Let's talk about the different bloats that we see. Like bloat in general, there's the term bloat.
Does bloat and colic mean the same thing? Or is it two
Yeah,
different?
yes.
Okay.
Yeah, in some fashion, yes. Okay, so the term bloat, there's a few different types of bloating, right? So what kind of bloats do we see and treat in emergency? What's like the first one that comes to your mind? That we actually call bloat.
The GDV?
Yeah, GDVs, right? Gastrodilation volvulus, right? So this is the one where it actually like fills up the stomach fills up with air, fluid, food, all of that jazz, whatever that's in the stomach, and then it what?
It twists.
It twists, it flips, right? So that's the full on what we consider and call bloat, right? However, there are other types of bloats too that we do treat in emergency, right? That are that we go, phew, it's not a GDV, right? So what are those?
That be like just in small animal medicine, or would that
Yeah,
be more
yeah.
like in horses?
Yeah, small animal.
Could we think they're bloated because they're in heat?
Because I'm sorry, because they're what?
Because they're in heat?
Not because they're in heat, but just that they're like, I mean, these are like really, like, don't think too hard on this. Like,
Because they ate something bad?
I'm like, what if they just got into their food, right? Their food bloat. Like a food bloat, right? How many of you have seen a food bloat? I mean, my dog was food bloat. I thought she was a GDV, and I was like, oh my gosh, like, here we go. And then I brought her in to work, and I took a radiograph of her, and she was a total food bloat. And I was like, oh, I'm going to let you suffer. You did this to yourself. I didn't let her suffer, but I was like, this is terrible.
I don't get it. What's the difference between a GDV and a food bloat? Like the GDV, it's like bloated because the stomach is pissing on itself. Like
okay, so a GDV is where it fills up with air. There could be food in there, right? But it's not because they purposely ate too much food. A food bloat is like if you went to a buffet and you ate too much purposely, and you just are sitting there because you're bloated full of food. That's what my dog did. That you're so uncomfortable and you can't even throw up because your stomach is too big that it can't even like move to throw up. That's how much food you ate. So even like there are times where you try to give apomorphone to make them try to vomit, and their stomach can't even contract because it's so filled with food that they can't throw up. So you actually have to pass a tube, like a stomach tube, to get the food out because they just engorge themselves with too much food. So, and then another bloat is just the G and the D, no V.
Gastric dilution?
Dilatation, right? It just means your stomach filled up with gas. Like sometimes their stomach just fills up with gas.
How did that happen? Not like.
And so what do we call that when their stomach just fills up with, well, how can that happen? What is one way that happens?
I've seen bulldogs that pant a lot.
Yes, I was just gonna say that. So what is that called? When they pant a lot and then they fill up with,
Just like hyperventilation or something.
okay. Or if they breathe in all of that because they're panting a lot, it's called Aerophagia. I think that's how we spell it. That could be wrong of how you spell it. Aerophagia. So they're like inhaling the air as they breathe because like well, this might be a shocker to some of you guys, but bulldogs, they have a hard time breathing.
Yeah.
That's a shock.
So they when they're trying to breathe, they like swallow air, right? So if they're swallowing the air, it's going in the stomach. So then all of a sudden their stomach can fill up with air, and then all of a sudden they're like, oh my gosh, it's all full and then this is uncomfortable. So then they come in because they got all excited. They were like, panting like crazy and their stomach's all full of air, but if they didn't become a GDV, they're just uncomfortable from the aerophagia. So it's like, phew, this is easy to fix. So we fix it with a lot of times with to get that gas to like move through. Which with guess what? Now we know why our bulldogs are so gassy.
Yeah.
Right?
So that could apply for any brachycephalic breed.
Oh, absolutely. Because they're gassy because of this.
Aerophagia.
Because this is all they do all day is they can't breathe. So they just breathe in all this air all the time.
Yeah.
So these are like the different types of obviously the bloats that we can't see. Now, emergency wise, right? Like the biggest emergency wise that we see are the GDVs. Yeah. Because this is the one that is twisted and is more, I guess I should say, more time sensitive. Yeah. Now, why is it time sensitive though?
Well, because it's twisted and then it would go in hypervolemic shock.
Ooh, good. Hypovolemic shock. Now, I know you know this because we've talked about it, but why is it hypovolemic shock?
I'll let other people answer.
Is it because of the blood?
Yeah. So the stomach twists, right? So that means that the stomach has twisted with probably a lot of other things, yeah?
Yeah, probably.
Right. So twisting with other things and it's cutting off a bunch of blood supply within that. Yeah. So that's why the second half of the body, which I'm saying is the back half of the body, has no blood supply. So it becomes hypovolemic shock. So this is why you get a bloat in and they say, don't put a catheter in the back leg. Don't ever do that. Don't put a catheter in the back leg because you start trying to give fluids into the back half of the body and it's not going to reach the front half, right? So we need to be able to get into our surgery as fast as we can to untwist that, right? And then also help with that shock, right? So now say you have this bloated stomach, right? It's twisted, it's pinching off all this blood supply. So what are some of the things that we can do to help relieve some of that pinching of the blood supply until we can get into surgery?
You put like a tube down their throat and then it releases some of that air.
Good. So yeah, we tube this animal, right? So we take a tube, we tube this animal. And so the tube goes into the stomach and then it decreases that down to this. So if it decreases that stomach air down, it's going to relieve that pressure onto the blood supply, right? So yes, it's still pinching off that blood supply, but we're able to get some of that blood supply back to the back end of the body, right? Because the air is not pushing on it as much, correct? So that's helpful. That's way, way helpful. What if we can't get that tube in?
Would you give colloids?
We would give colloids during this time, yes, to kind of build up like our protein and also help to build up our blood pressure, yes, but not in this case right now. Like it doesn't apply to this right now, that would be for something completely different. So, but what would we be doing right now if we can't get this tube in? What's another option we could do? What is it called, the procedure?
Would you do like a G, is it called the pressure point, the G26? To get more
No,
oxygen?
no.
I don't know what it's called, but do you place the needle into the stomach?
Yes, good. So it's called Trocar. So yes, you take, essentially you're gonna take just an IV catheter, right? And you're going to go where you take, like you hear a pinging sound, like the largest ping sound. So you'll like flick onto the abdomen, and you're going to make sure that you can hear that the strongest. And you're going to insert your catheter there. Wherever you insert your catheter, then you can remove the stylet and leave just the catheter in there, and remove your nose from that area, so because it's going to smell really bad. And then relieve that pressure there. So now, important question is, what side of the animal's body are you going to insert the needle?
On the left side? I think. I know the pinging thing, that's something that's done frequently, like with large animals, like for cows.
Mm-hmm.
I thought that was something that was done with dogs and cats. Well, probably more dogs.
So if you have, typically, if you have your animal on, what I do at least is that if I have you have to think of where your spleen is located, right? So what side of the animal is your spleen located on?
That's a good question. Gotta brush up on anatomy.
Left side.
The left side? Okay, so if your animal's abdominal, if the abdomen, or I should say, the stomach flips with the spleen, because it usually flips with the spleen, where is your spleen gonna land?
Right
The
side.
right side.
On the right side, correct?
Mhm.
So where should you poke?
On the left side, so you don't rupture your spleen.
Perfect. So you should poke on the left side, correct? So, I mean, they're not gonna rupture the spleen with a poke, right? But you definitely don't want to make it bleed, right? So, yeah, you want to poke on your left side so you don't poke it.
What happens if your spleen didn't twist with the stomach and it's on the right side, and then you accidentally poke your spleen?
Then you accidentally poke your spleen. I mean, like, it's not the ideal, but like it usually twists with the stomach, so it's going to go on your right side.
Okay.
So then you're going to poke the left side, right?
Mhm.
Sometimes you might get the tail with it, so you sometimes will hit, like I've seen people hit the spleen. So because some animals do have a very large spleen, and it just happens, and so I've seen that happen. So yeah, it just depends. I mean, the animal's obviously an emergency state, so like it happens. So okay, the most ideal thing, like I said, is going to be to get a tube in, and that would be the best, but just do the best you can. Okay. So where was I going to say next? So we talked about Trocar, and then we have our tube. We get them under, we bring them into surgery, and we have colloids going, crystalloids. What are our shock crystalloid fluid rates for dogs?
For dog, 90.
90 mils per kg. Good shock.
I always think cats is like 50 cents because you're more likely to find a cat on the street, and dog, they're very desperate. So people want breathers, so they're more expensive. So they're $90.
Oh, okay, perfect. 50 mil. All right, perfect. So there's your shock, right? Awesome. And then we have, so those are shock, right? How to start.
Quarter dose.
Okay, sure.
I remember that.
I mean, we always start at a quarter dose for everything. So head of starch is going to be 20 mils per kg per day. And then Veta starch is 50 mils per kg per day, right? And so purpose being for these guys at this time is that our blood pressure is definitely not the best, right? Because we're in hypovolemic shock. So in this case, we're going to try to use these guys to build up our blood pressure. Now, in a bloat situation, when we're cutting off our blood supply, right? What happens to tissues when we cut off our blood supply?
Necrosis.
Yeah, it starts to die right away, right? Like, it's like, oh my gosh, life supply done, we're dying. So what is the way that we can measure our let's see, a way that we can measure our like tissue essentially, or I'm trying
You
to
do biopsy or like a CBC?
I'm trying to think of like, we're not going to do no how to describe this.
I'm doing my notes, and so we said that the spleen is on the left side, usually?
Correct.
Okay. So with the GDV, it flips with the stomach and it ends up on the right side. So that's why we're poking on the left side.
Mm-hmm.
Okay, cool. Thank you.
So trying to think how I want to describe this. So how do we measure like our tissues just trying to think how if we're suspecting any type of like cellular damage, essentially, how would we measure that? There's a blood
Would you do a blood smear?
No,
Like a biopsy of that blood
no,
tissue?
Do a
because
blood-
we would have to actually do like, we'd have to go in. There's an easy way to obtain blood and do blood work on an animal to know if there's cellular damage of tissue.
Do you do a blood gas analysis?
No. So this measures like, do you guys ever talk about lactate? Oh, let me learn how to write.
Lactated ringer?
Nope, just lactate.
Like the enzyme lactate?
Mhm. So a lactate should be less than 2. So I ever talk about like, oh, your lactic acid, like after you go running, right? And you're like, oh, I built up my lactic acid and I have to, you know, like drink a lot of water and all of that, you know, to like,
Check the ATP?
to like flush out all of that stuff that you've just built up, all that lactic acid and all of that, right? You gotta, all that energy that you just built up in your muscles and all of that, correct? So if you have a patient who has had all that blood supply cut off and all of that, is built up all of this lactate that that has the cellular damage essentially. And so if we take it, literally, like you can get, it looks like a glucometer. It's a it measures lactate, and you just take like literally a drop of blood, just like the glucometer strips, and it'll measure like what their lactate is. And so like in GDV cases, you'll see like it'll be like 5 point something, right? Like when they first come in. And so the idea behind it is, okay, this is what they're starting at, right? Like they're where they're at essentially. And so if we start diuresing them, if we go into surgery then and we flip back their stomach and we're monitoring them like a serial monitor, just like how we do for glucose, we want to make sure that we get back down to their lactate back down to less than 2 at whatever point before they go home, so that their tissue is viable again, right? Because we don't want it to become necrosis. Like by the time they go into surgery and they fix it, what they close back up, we don't know what it's going to look like by what day is it when it can dehiss. What's the magic number day?
Is it 3 to 5?
Oh, good. It's like day 4, right? Day 4 is like magic number day. So we don't know what it's going to look like that day, right? So, but we can monitor it outside the body with our lactate and go, okay, well, it's looking good this over here, so we should be okay, right? Our tissue looks viable this way, right? So this is a good way to at least monitor how things are looking on that end, right? So it's just a way to make sure that everything's looking good. So when they first come in, it's nice to have a baseline of, okay, this is like how really bad it is. And then by the end, hopefully we're like back into the normal range before they go home. Does that make sense? So there's a lot of factors that kind of help with making sure that we get back to that normal range. Yes, a big one is fixing them surgically, but other factors is diuresing them, of course, like nutrition, all of that. But it's a lot of supportive care essentially too. So, okay. So what are some other things that we worry about with GDVs? Like when they first come in to going home, what do we have to like worry about?
Arrhythmias.
Ooh, arrhythmia is our favorite, right? I know it's your favorite, Alicia, like we've talked about. You're like big worry, arrhythmias. So what's a big one that we see? A big arrhythmia that we see with these guys? It's probably one of the most common ones we see. But like my heart hurts. What are you gonna see?
You see the PVCs.
Yeah, so you're gonna see it most commonly VPCs, and so you'll see that, you know, throughout them being there. Even post-surgically, you may see VPCs, but hopefully over time they're going to improve. So, and a big reason why is, again, hypovolemic shock as well as pain. They're in shock and pain, right? So that's a huge reason why you're going to see those VPCs. So essentially, we're supportively treating them, right, with fluids, and then also with pain medication, because that's our favorite, right? Because we're their advocates in this. Doctors are like, their minds are on how to fix the situation, right? Our minds are on, yes, fixing the situation, but also like, hey, this animal is in like pain. And so we got to fill the holes for the doctors, right? So we have to be like, hey, can we give pain meds here? Hey, you know, should we place a second catheter? You know, like, because they're going to need it for X, Y, and Z. So we have to kind of fill the holes where they are like onto the next step and maybe have missed those steps. So so yeah, if they're having VPCs, it may not necessarily be like, oh my gosh, we have to give them, you know, lidocaine right away. Like maybe they're just in severe pain. That might treat it too first, right? So what are some pain meds we can give first? Please don't say Torb.
Can do hydromorphone.
Yeah, I would at least start a hydromorphone, right? Like this is a pretty decent painful experience. And we're going to also think on long-term effects of like, this is going to be a long procedure for surgery as well. And they're going to be staying afterwards. And we're also going to be continuing pain medication after procedure wise. So we want something that's going to be a longer affecting pain medication, sorry. So we could do hydromorphone right away. Also, we want something that's going to be a quick and simple medication to give them. So we can do maybe like a CRI in surgery. Like if we want to talk CRI, so you probably do a CRI in surgery, but like right away, let's just give an injection of something, right? So I think like hydromorphone is like perfect to start out with. And then once we get into surgery, I love the idea of like, let's talk CRI and add in that too, because that's going to be really helpful, like post-surgical. So hydro is awesome idea. And then CRIs are always fun to talk about because you can do, you know, fentanyl if people have, oh gosh, if people had methadone and stuff, that's even better, you know, to even chat about, but not everyone has it because it's super expensive. And then you can even do ketamine, lidocaine on top of that, because that's going to be helpful. You can do dexmedetomidine in there, like little amounts, you know, stuff like that. So there's a ton of like really cool things to help with. But again, this is going to help for pain, and potentially going to help with those VPCs. Now, if it doesn't help with the VPCs, then what's your next step?
Lidocaine.
Lidocaine, right? So why does lidocaine help?
What's a BPC?
Okay, so what's a VPC? VPC is ventricular premature contraction, right? So that means that in our normal ECG, our QRS, that's right here, cuts in line of our P wave, that's right here. So instead, it kind of looks like this sometimes, or it can look like this. Or it can look like so many different things. Or it can look like this. I don't know, I just kind of do the same thing. This one's kind of stupid. It kind of looks like that.
It's like an insane arrhythmia,
Yes.
in other words.
They're called wide and bizarre, essentially.
Wide and bizarre.
Mm-hmm.
So you ask why we use lidocaine for that?
Yes. So why do we use lidocaine?
Well, our heart is a muscle. And lidocaine is a local anesthetic, usually muscle. So I'm guessing you're anesthetizing your heart to reset it.
Correct. So yeah, we're kind of just making our heart like relax a little bit, right? Because it's freaking out at that present moment, right? So you want to like let it relax a little, and yeah, to kind of reset everything as well. So do we need to do like a lidocaine CRI right away, or do we just give an injection of lidocaine? You're like, I don't know, that's the doctor's job.
Maybe a CRI? Maybe.
So usually we just do a dose of lidocaine first and see what happens, right? And if it converts over to just like a normal rhythm and it's fine and it stays that way, then we're good. If it goes back to VPCs again, then we'll consider doing like a CRI. But sometimes just one injection does the trick, just depending, but sometimes they have to go to a CRI. So it just kind of depends. All right. Any questions on that? Any questions that you guys have in general?
I have a question. The FIG, you have beside the aeroplasia, is that FIG X? That's written?
This is gas X. Sorry, my G's are weird.
So that's like surgery to like remove gas?
No, it's a drug.
No.
It's like an over-the-counter drug.
That you would give how? Like in the DT tube? Or like?
No, orally.
Oh, okay.
Yeah.
Would you
It's
use
like in
that?
the same aisle as Tums.
No.
Probably. I don't know why. Probably.
So like, would you use so could someone just say, my dog is farting an awful lot, I'll just give him gas X, hoping he'll stop farting?
Maybe. I don't know. Usually like gas X is more like if they have like built up amount of gas is making them uncomfortable, not necessarily like if they're farting a lot.
So how would someone identify my dog is uncomfortable because of too much gas in their stomach?
I don't know that owners would identify that versus like we would identify that. Like a lot of times like we could identify that because we see it on radiographs, or like we could just, I don't know, we have that natural feeling. No, you know, just like just from a history that we take or whatever, like, or we just say, let's try this and see if it helps, you know, like that type of thing. So that's part of it, I guess, but not necessarily that owners at home just go, oh, I just have this feeling per se, unless they're like very in tune to their dog. So
So like, let's say for like food bloat and like GD, it's like a weekend, the clinics are closed. It's not like a super life or death situation because we don't have the GDV going on, but like, I don't know, can an animal actually like die from food bloat or like GD?
Can an animal actually die from food bloat? Oh, I don't. I've
Or is
never
it-
seen an animal die from food bloat. Um,
Or is just like, I'm so stuffed, I'll rub my belly until I fall asleep, kind of like when we go at the buffet and eat too much.
I'm trying to think about if an animal could die from food bloat. I think though their stomach could potentially rupture. But they can be incredibly uncomfortable. Because they can't vomit it up. That's the other part. And the other thing too is that who knows what they ate. So like to become a food bloat.
So like, let's say like, so like our DVM to diagnose and like determine what it actually is X-ray the only tool that they can use to determine that?
No, but like we could, who knows what they ate, but if they're incredibly uncomfortable too, is that we can remove that food. Like we have the tools to be able to remove that food. So like, even if we can't get the food out from like apomorphone, we can pass a tube to get that food out, to lavage it out. So I think
like,
that that's also important, is that if they're that incredibly uncomfortable, that it's important that we actually do remove that food, or say that they have ingested medications, like who knows if it's a toxin or something to that nature. Like we don't want to keep them incredibly uncomfortable for who knows how long.
So like, if I'm thinking from a point of view, what do they have all in common? Like, what's like something that we can do that like in all three of those situations we could do?
So they're all uncomfortable.
No, but like as techs, like what is like standard procedure that we that as techs we can do like in those situations that we know like it's always the same thing?
Relieve their pain and fix them. Like I don't know what to tell you. Like there's a lot that we can do. There's so many different procedures to be able to fix them. There's supportive care, there's surgical procedures, there's there's a lot of different procedures. And the thing is that these are not things that owners can do at home. So yes, there are small things that owners can try at home if they're not severe, right? Like, there's some tiny food bloats that they can, be fine at home, like, and they can just do supportive care. But I've seen really, really bad food bloats too that shouldn't sit at home. So I'd never want people to feel like, oh no, they can all sit at home and be completely fine. That's not the case. Like it is uncomfortable for patients. And I don't want people and I don't want technicians to be at home advising owners of certain things that owners can just do at home. I don't think that that's appropriate. I think that we still need to be advising owners to still go to their veterinarian and seek treatment.
Yeah, for sure. But what I was more implying is like, as far as pain management, like, and like IV fluids, what are like the more specific drugs that we would be like to administer in those situations? Or
right. So
that
for food bloat, yeah, they're going to be dehydrated, right? Because if we're trying to like make them vomit or getting them to vomit, then they're going to be dehydrated in those cases. So we would definitely in that situation be giving them fluids. They're going to be uncomfortable too. So we'll probably be giving them some sort of pain management, probably not like hydromorphone, because that well, unless it's really, really that uncomfortable, but maybe like even just buprenorphine, it's probably fine. Because we're probably not going to keep them that long. It's not going to be like a surgical procedure or anything like that, but at least just like something that's, you know, because they're uncomfortable. If they have like just gas filled stomach and it's severe gas filled stomach, we'll treat it like a food bloat, right? So like if they have to have a procedure where we need to place a tube down their stomach to relieve the gas, we can do that too. So I've seen that done as well, where we needed to do that. If it's something that we can send them home on just like gas X to relieve it that way, like if it's not that bad, then we have done that. But there have been certain ones where we had to place the stomach tube to relieve the gas. And, you know, of course, we've always administered some sort of pain management for that because it is uncomfortable. So whether it was, you know, like Torb or buprenorphine or something to that effect, they've always been, because they're on sedation for that, they've always been on IV fluids during that time because we want to make sure that we flush out that anesthesia like as much as possible as they're waking up and stuff too. So yeah, I mean, those are the important things, I think, is that there's always going to be like minor cases and then up to severe cases of like how bad those things are. So.
Yeah, makes sense. I have a question for one of the pharmacology questions I was doing.
Okay.
Before I do that, is there anybody else that have any more questions? I know I talk a lot, so feel free to jump in your questions. I will.
Go ahead.
Okay, cool. So the problem that I was looking at where the answer was 6, and I was so confused as to how the answer was 6, is that the prescription, which had 3 milliliters of lactulose, was given orally twice daily, and then will require how many ounces to last 30 days. And then what I did initially, I was like, okay, 3 milliliters times 2, 6 milliliters of lactulose per 1 day. And then I did, what did I get? 6 times 30. Oh, 6 times 30 days. I got 180 mils. But then the answer was 6. And I was like, how?
Okay, so sorry. The question was 3
mils of lactulose orally twice daily. And then they're asking how many ounces do you need to last 30 days?
Okay, so you need 6 mLs, right, per day times 30 mLs, or 30 days, duh. So 6 times 30 is 180, right? And then, so this would be divided by how many mils are in an ounce?
I know
Is
that
it 30?
30 mils in an ounce?
30 mil.
30 mils per ounce, right? And so if we do 180 divided by 30, how many ounces then do we have?
Divided by 30. 0.1. 6. 0.16. I got.
Okay, try that again. So we have 180 mils, right?
Mm-hmm.
That we had
Divided
total.
by-
And then,
oh, 6. There we go.
yeah. And then we need to figure out, right? But divide that by 30 mils per ounce. So we have 6 ounces.
So the only thing I was missing was divide your 180 by 30
Mm-hmm.
for the conversion.
Mm-hmm.
Cool. So the conversion issue I had.
So it's conversions. They're gonna
Work
kill
on
you.
those. When I saw that, I was thinking of, okay, 1 pound equals 16 ounces for some reason, because I know that pounds looks like a 16. So I was like, okay, I know that. But
Well, and then how many of you guys actually have to put or have lactulose or have ounces of stuff in clinics right now? I mean, we deal with that quite a bit, right?
Mhm.
So, so yeah, it's definitely something that's somewhat common, right? Like we have lactulose, we have gabapentin is one. And the gabapentin now is like controlled in 5 states. Yeah.
Yeah.
So I don't know in Canada. And so like, so it's one of those things that like we have to be better at with conversions, you know, on that end of things. So.
Mm-hmm. Oh, my other question for that. You had a question where you were talking about Unison that you give IV.
Unison?
Yeah. what does
Okay.
that do?
Unison?
Yeah.
Good question. So this is what she's asking. Unison.
It was a reconstitution question.
Yeah. Anyone ever use Unison?
I used it for the first time on Thursday.
Ooh.
That's exciting.
So what is it? It's like Tomentin. You know what that is? They're both very similar.
Menton.
What is it? What is it? What is it?
It reminds me of the Titanic, but that has nothing to do with this.
So they're injectables, okay?
Injectables that you can give IV, that we know.
Yeah.
We have that in a problem.
So tell me this. What category of drug is it? You just gave something you didn't even know what it was. You were like, here you go. You just have.
I'm not the one that gave it. I'm just
I
trying
know.
to figure out this problem.
You just gave liquid something. So it's an antibiotic. They're antibiotics.
Antibiotic.
Let's start with that. So let's compare to one of our oral medications because that's the easiest way. It is one that you guys give all the time. All the time. Which one do you think it is? We'll do like a guessing game. Which one? Which one do you think it is? It's not Baytril because Baytril has its own, right? Anyone? Anyone? It's like
So let's see. Antibiotic. Antibiotics protect the queens, men, servants. Sevoflurane. Men was mannitol? No.
so Unison is very similar to Clavamox, right?
Flavomox.
So it's the amoxicillin and clavic acid or whatever.
Okay. Unison equals Flavomox. The memory I had for that when I worked in wildlife rehab, anytime we would have like a bird where it had contact with the mouth of a cat, we would give it Flavomox because oftentimes they would get infections.
Awesome. Great.
I have a quick question. So how does Unison kind of relate to ampicillin sulbactam? Because that's what we use.
Great. Yeah. So, and that is a perfect question. So just like how we have Flavomox, right? So we have Flavomox, and then we also have amoxicillin, right? So these two are very similar in the fact that they both have essentially, they're in the same category of like the amoxicillin category or amoxy category, but this has the clavic acid in it. So ampicillin is still like what we would put in essentially the amoxicillin. It's very similar to the amoxicillin. And then Unison is very similar to that Flavomox, if you kind of look at it on that end of things. So it's just slightly different if we compared it to the orals. Does that make sense?
Yeah.
So it's just, it depends on like how we want to, depending on how much or how we want to treat certain things for our patients. So honestly, usually we're going to use our ampicillins more than like a Unison or its Menton. Ampicillin is going to be a lot cheaper, to be perfectly honest, and it's obviously going to be more broad spectrum. And I mean, Flavomox is still a very broad spectrum, but amoxicillin and ampicillin is going to be really broad spectrum. And so we use it quite frequently. You guys use ampicillin probably do you guys use it for like your surgical procedures and all of that?
Yeah, we use it in a lot of like hospitalized cases too.
Okay, yeah. So a lot of times for like Unison and Menton, we would use that stuff for some of like the more like, I guess I would say if they're not responding to the ampicillin or in addition to ampicillin, or some of the weirder cases, I guess, I don't know, like some of the more critical cases too, that they just felt like needed, Unison or Menton. They just used that. It just kind of depended on it. So yeah, it just depended on it. I mean, they also use like cefazolin for certain ones too. I think it just depends. Obviously, like enrofloxacin is another one that they used for like some of the more critical ones. I think ampicillin is like their first go-to, just like in human medicine. Like amoxi is the first one they're going to go to because it's, one of our first antibiotics that was invented, right? Our penicillins are our first invented antibiotic. And so those are our first strain that we're going to use right away if possible. So that's a great question though.
I have another of those questions.
Yeah.
There's another question where you're talking about aminophylline and then asking
Aminophylline. Yeah,
Yeah.
aminophylline.
it's used for pulmonary edema, but like, how does that work? Like, what type of drug is this?
Right. So, aminophylline, yeah. So does anyone use aminophylline? Probably in emergency. Probably not that often, I hope. So we're going to use aminophylline, obviously, in our more critical heart cases, right? For pulmonary edema, in those critical ones that come in, or respiratory ones too, if there are respiratory issues, then we'll use those. In the question that I had, I believe that one was the one who bit the electrical cord or something, right?
Yeah, it was your 60-pound patient who bit through an extension cord. Has orders to give. You have orders to give the aminophylline.
Aminophylline, yeah.
Aminophylline.
Yeah.
Yeah, you're 7 milligrams per kilograms IV every 6 hours, with a concentration of 25 mg per mil. How much will you be giving to this patient for each dose? And then it asks, what is that word? Aminophylline. What is that?
It's hard because when you look at it, the aminophylline is not what comes to mind when you go to say it, I guess.
It's the pH that screws everything up.
Right. So so this is an interesting one because when they bite an extension cord, right? They get pulmonary edema as a secondary effect, right? So essentially, the first thing that happens would be what? Would you think, at least?
Shock.
Yeah, like they get shocked, right?
Mm-hmm.
The burns in the mouth, stuff like that.
Yeah.
Right.
But also, like, the animal would be psychologically traumatized. That was the first thing that
you would think, but they'll go back and do it again.
True.
So then, if we aren't careful enough, or owners think that they're fine, they just go back to doing what they're doing. Okay, they're fine. There's nothing wrong, whatever. But what happens is that afterwards they have a hard time breathing and they're like, well, what the heck's going on? So they come in and they have pulmonary edema from what happened. They were actually shocked, like literally shocked, or electrocuted, right? So
can you talk about what pulmonary edema actually is, though?
Yeah, anyone know what pulmonary edema means or is?
Edema, I know it's swelling of some sort.
Yeah. Who else said something?
Fluid buildup within the lungs.
Okay, so fluid buildup within the lungs. So explain that a little bit more. Because there's kind of like there could be two different interpretations of that.
Is it more within the sac that surrounds it, or is it within the alveolar tissue?
Within the tissue. Good. Yeah. So and I asked that because there's edema and then there's effusion, if you can remember. So edema means like think of your limbs being edematous and it just swells up, right? So it doesn't mean like you can tap your leg, like take a needle and suck out the edema in your leg. You can't do that, right? But if you have effusion, you would be able to like actually remove the fluid, right? So same thing with your lungs. If it's a edema, you'd be able to like actually remove, if you have edema, you actually can't remove that fluid. If you have effusion, you can remove that fluid. So pulmonary edema, in this case, you can't remove that. So in their case, they wanted to do aminophylline and to help this patient, right? So
Like, how do you get like pulmonary edema from like electrocution in the mouth? Like, does it like swell from the tissues and it just keeps going down the like?
it's
I don't know.
from the shock of that animal from the electrocution.
So would it would actually burn all the way down there?
Mm-hmm. Yeah.
Oh, it's crazy.
So aminophylline itself, what category drug is that?
Sounds like Lasix almost.
So it's not necessarily Lasix itself. Like, I'm sorry, it's not a diuretic. It's actually a bronchodilator. So it's going to help kind of dilate everything out. So in this case, it's a little bit different in the pulmonary edema itself because you're getting swelling because of the shock, right? Everything just kind of like goes, oh my gosh, you know? So when we have like pulmonary edema from fluid overload, we need Lasix because we need to get that fluid out, right? In this case, with shock, or I should say electrocution, because I'm just saying shock all the time. Electrocution, everything is just like traumatized, right? So it just kind of swells up. So that becomes adenomous. So it's a little bit different. If we just give Lasix in that case, there's nothing to come out, right? There's no fluid to come out. So what we need to give is a bronchodilator to help this patient breathe. It's just like if this patient was having an asthma attack, right? And we were like, well, just give them Lasix. Is that going to help the patient with an asthma attack?
No.
No. We'd be like, oh, okay, that was a good try. Now what are we gonna do? So say this patient is having an asthma attack. What drug do you think we would give it?
Bronchodilator?
A bronchodilator, right? Well, guess what? Aminophylline's a bronchodilator. So we could actually give it aminophylline as well. So this is actually very comparable. I'm not saying like, oh my gosh, an asthma attack and biting an electrical cord is the exact same thing. It's not. but it is very similar as the fact that, hey, they have shortness of breath. They can't breathe, right? So we can give a bronchodilator in this case. And the fact that we can't give Lasix because it won't work. So, and so that is a huge reason why, hey, we can't treat them all the same way, you know. And pulmonary edema can mean many different things, you know. It doesn't mean like, hey, we're fluid overloaded either. So hope that makes sense at least.
But like, what's the actual difference between Lasix? Lasix, that's a new drug for me. I just learned this right now. I'm like,
Lasix and furosemide are the same thing. Sorry,
Lasix and what? Furosemide?
Furosemide, yeah.
And what do those do? I heard fluid. I heard.
Okay, so furosemide is a diuretic, right? So I've talked about furosemide. And then so furosemide is your generic name.
Okay.
And then Lasix is your brand name.
Got it.
I don't know what they are in French.
I don't know either. Look that up more. Lasix, you call it?
Yeah.
Oh. Diuretic. That helps you pee.
Yes. It's like drinking coffee. Coffee is a diuretic. You didn't know that?
Yes, I knew that.
Oh,
Alcohol
okay.
is also a diuretic.
Yes. Yep. I know you guys
Um,
can list all the diuretics.
So like your Lasix, would you give Lasix in a block cat? Try to make it pee?
No, absolutely not.
No? Okay.
It won't work. Don't do
It
that.
won't work.
Don't do that. You'll
Okay.
just make that poor cat miserable. Please don't do that.
It'll blow up the urine more and build up the potassium more.
Yes. Yes.
We don't want to do that.
Yes.
Well, switching to something kind of different with the conversions. You had a question where I was asking what were the right conversions. No, actually, which one were the wrong conversions? So I figured out which one was the wrong one, but I wasn't sure how do you actually make that wrong conversion right. So that was the 1 UG equals 100 milligrams. And I was like, oh,
1 UG equals 100 milligrams.
that's microgram, right? The UG?
Yes. So that was the wrong one, right?
Yeah.
That just sounded really wrong. Okay. Okay. So you wanted to make this correct. Is that
Mhm.
all right? So 1 microgram. All right. So if we want to make 1 microgram, what is 1 microgram equal to?
Oh, 1,000 milligrams. 1 3 zeros. Actually, no, that was the wrong one. Never mind.
You're thinking of this backwards. A microgram is smaller than a milligram. So it would be 0.0.1 milligrams. Because it's 1,000 milligrams, right? Or 1,000 micrograms, sorry. 1,000 micrograms is 1 milligram, right? So 1,000 micrograms is 1 milligram. Is that correct to say?
1,000 micrograms equals 1 milligram. Is that what you just said?
Yeah. So 1,000 micrograms equals 1 milligram, correct?
Yeah.
Okay. So this is 1,000, correct? Okay. I'm just making sure that I did that right. Okay. So this would be the correct statement right here.
Okay.
Or this could be a correct statement.
Okay. Keep mixing up my thousands and my hundreds when I say them in English. Okay, so 1 microgram equals 0.001 milligrams. Is that what we determined?
Yep.
And then you have 1,000 micrograms equals 1 milligram. Cool. And that's universal. That's what that always is. So let's say we need to convert that. I would have to do times because microgram is tiny. So any conversions would make the microgram bigger. I'm guessing.
Yeah,
that makes sense.
Cool. All right. Any other questions? I know Melody would always have a question. So any other questions for everybody else?
Oh, if nobody has another question, I have another question.
Oh my gosh, Melody.
I told you.
Why do you have all these questions?
We didn't have a lecture last week.
I know.
I come prepared to class.
Yeah, you do.
So, my other question got me kind of confused. where I put, what is the difference between a bolus and a loading dose?
Ooh, good. Yeah.
Because your
Bolus and-
question for that was sometimes drugs are first administered in a large dose and then given as a series of smaller dose. What is the
Yeah.
first dose called? And then we determined that's called a loading dose. But I'm like, but
Mhm.
bolus is when you put it all at one time. What? I was just really confused.
Yeah, no, that's a good question because this is something that we do for like certain patients that we're giving like phenobarbital to and then like even Keppra and stuff is called a loading dose. So this is a really good question. So a bolus. So do you have that question?
Yeah,
With
I
you?
have it right in front of me.
Okay, so what is the question again?
So the question is, sometimes drugs are first administered in a large dose and then given as a series of smaller dose.
Yeah.
What is the first dose called? And then
Yep.
your answer choices, you had distribution dose, initial dose, loading dose, and bolus dose.
Yeah. So this was one of the VTNE like questions, I'll say. So so yes, so you're right on the fact that we call like say like an anesthetic drug, we'll say that we bolus a drug, but we don't give smaller doses later on, right? Like that's just not something to do, but we do give medications to animals like a loading dose, and then we give smaller doses later. So some of them are like I said, phenobarbital, Keppra. Other ones that we also do would be like meloxicam. You guys give a larger dose the first day, right? Typically. And then you give a smaller dose the second day and then thereafter. Or like if you guys do Albon for coccidia, anyone do Albon still? Some people do. You'll give a larger dose the first day and then the next days you give a smaller dose the days after. So there are some drugs that we have to do that for. So those are called your loading dose. And then you give your regular doses after that.
So loading dose meaning kind of like you just said with your meloxicam, where you give your first dose where your meloxicam, it lasts for 24 hours, and then you would give your the smaller doses in syringes. And then
like whatever. Yeah. Now, anyone do any loading doses for phenobarbital ever? Loading dose for phenobarbital is a little bit different. Anyone ever do them?
Haven't heard of that.
So for phenobarbital, we do it a little bit different. So in phenobarbital, we have done it like in emergency setting. We'll do it in a series of 4 injections. So this is like pheno, and we also do this with Keppra and Keppra. So you have like it's like a loading dose, so like a big dose, right? And then we'll break it up into 4 different injections because we don't want to give it all at once because that'll just knock them out altogether. And it can be kind of dangerous then, right? We don't want to do that. So they have this big loading dose that we have to give. And so we'll break it up into 4 injections. And so we break that up into 4 injections. We give it usually we'll give it over like each injection like every 2 to 3 hours. We'll break it up. Sometimes people will spread it out even further, and we'll give it slowly. So 2-3 hours apart, we'll give it. Does that make sense? So like we'll give 1 injection and then like 3 hours later, give the next injection, 3 hours later, give the next injection, that type of thing. So even though we're spreading it out with that, by the time they're done with that loading dose, those animals are still pretty sedate. I've even had it where like some of those animals, because they had been seizing like all of that time, and they get loaded with the phenobarbital, they are knocked out and they have to be there for like the next day or two because they're still like knocked out from phenobarbital. Anyone ever see that? It's good because it's not fun. It sucks. Because think about it, like typically an emergency case, like many of you guys may have seen, like they're starting phenobarbital, so we get them on a loading dose phenobarbital orally. And so that's fine. You could do that and it's perfect because you can orally load them on phenobarbital to get them started. But on emergency, we have to get them started orally or get them started quickly because they're already like seizing like crazy. They've been like a status and it's bad. So we have to load them fast and get them going. So like we're giving them IV phenobarbital and that's a mess, right? So we're either loading them with phenobarbital and or they're on like diazepam too. So they're like knocked out. And so then after that, we're like, hey, let's try to get you up and moving and walk around. And they're like, we are so drugged up. Right. So, yeah, I mean, sometimes it's a good thing because in a sense that they're resting because their mind has been like, their brain has just like been in all sorts of craziness in the last day or so. But at the same time, you know, we want them to be at home with their owner too. And, you know, they're more comfortable with their owner too, you know, so, but yeah.
So when we're talking about phenobarbital, what particular situation would a vet prescribe phenobarbital?
Okay, good. So in this case, it's seizures, right? Phenobarbital are anticonvulsant. So most of the time we're going to do phenobarbital, or I should say all the time it's going to be that. Diazepam is used as a to stop our seizures, right? Okay. So this is as a anti-seizure medication to treat and help with seizures long term. So yeah, that's like one of their go-tos for pretty much right away. Now they are going to use Keppra as well. So it's going to be like pheno plus or minus Keppra, or we have like potassium bromide. We have zonisamide as another drug that they can use. It just kind of depends on what seizures that they are going through. Like if you have a generalized seizure, if you have focal facial seizures, like neuro is a whole other story. So yeah.
So depending on what type of seizure they're having, they'll get different medications according to their symptoms.
Yes. So most of the time in general practice, we're going to see our generalized seizures, right? Mm-hmm. So, and then when we start seeing weird seizures, we send them off to neurology, right? Because they're weird. I've actually like helped and work in neurology, so I have seen the weird seizures. So that's kind of how I know like the weird ones. Plus my dog has like weird seizures. And even sometimes when we think that they're weird seizures, they may not actually be seizures itself. So sometimes they can be anxiety induced. So they're not actually seizures. They're just anxiety looking seizures. Sometimes they're actually, depending on breed, can be due to GI issues. And so, you know, whether it is fly biting, stuff like that, that actually may not even be a seizure itself, and it could be just due to GI issues. And so that is something that just needs to be addressed a little bit wise from internal medicine standpoint. And so it just depends. So just starting them on phenobarbital might not be just like, hey, we just need to start phenobarbital. So that's why like working them up is important too. So that's a whole other discussion. So
for that, then just make sure I understand the difference between our loading dose and our bolus. So our loading dose would be when you give one big dose and then break it up. So like you just said, the phenobarbital, you would give one big dose, then break it up in 4 injections every 2 to 3 hours. But then your bolus is when and you're giving it IV. You're like in your IV bag fluid.
Right. So our bolusing is like, hey, we're bolusing like fluids, or we're bolusing, you know, like bolusing just means that we're giving like a one-time thing, right? We're just bolusing something, like a one-time injection of something. If we are doing a loading dose, that means that we're actually going to be dosing out something to someone, and so they're getting a loading dose of something so that we can get them up to they're going to have to reach some sort of therapeutic range, right? So we need to get them up to that therapeutic range quickly. So that's why we have to give them a loading dose, so that the regular dosing that we're going to be giving them the rest of the time is okay. So if we don't give them that loading dose, it's going to take longer to get to that therapeutic range. That makes sense.
Yeah.
That's why we give the loading dose.
So that way you're giving a big dose, but it's not too big that it'll make them crash or anything like that.
Right.
Okay, gotcha. This is so exciting. Learning so many new things tonight. Today, I should say. See, this is what happens when we miss like one day of lectures. I have like a gazillion questions for you.
Awesome. All right. Anything else?
I have another drug where you're talking about I can't even say it, diphenydrate elixir, 25 milligrams PO for 12-year-old beagle.
Trying to think.
It's DIPHEN HYDRAMINE, and then
diphenhydramine. Okay.
Helix. Yeah.
Okay.
Big word.
Okay.
What does that do? Because you're giving it in your question, you're giving 25 milligrams of it PO for a 12-year-old beagle. That's like 12.5 kilograms, and the solution concentrate is 12.5 milligrams per 5 milligrams, and then you're asking what volume should you give to the patient. But I'm like, first of all, I want to know what the heck is that about, that drug.
Okay, 5 mils. And then how much to give?
What volume should you give to the patient? And then your answer for that was 10 mils.
Okay.
Because when I did my calculations, I did 12.5 times 25 divided by 25, and I got my 12.5.
So they want you to give 25 milligrams, right?
Yeah. Of the can't even say the word.
Diphenhydramine.
But what does that do? What category is that?
What's diphenhydramine?
Yeah. What is that?
It's Benadryl.
Oh. That's a big word just for one brand name.
That's your generic name. Do you buy diphenhydramine? I'm sorry, do you buy Benadryl, the brand name?
No.
Okay.
I don't really use Benadryl, so I was like, what in the
well, okay, so you need 25 milligrams of diphenhydramine, and your concentration is 12.5 milligrams per 5 mils.
25. Or is it?
But you need 25, right?
12.5. Yeah, we need 25.
Okay. So there are two ways of doing this. You can take 12.5 milligrams and divide by 5 mils to figure out how many milligrams are in per mil, and then figure that out. Or you can realize that, hey, I need 25 milligrams and this is 12.5, and I just needed to double that.
Mhm.
And then that means that I just need 10 mils, right?
Mhm.
Ooh. Yeah, that makes sense. And then, yeah, I did that, but then I got like the 12.5 and I'm like, there's no 12.5 in there. So I just went with 10 with that, because it turns out that was the right answer because it was the closest thing to 10.
So, I mean, okay, so 12.5 divided by 5, right? So say this was
Divided by
something,
25.
so say this was something weird, like not 25 milligrams,
Mhm.
right? So the concentration of this would have been 2.5 milligrams per mil, right?
Mhm. Yeah.
Okay. So you need 25 milligrams. So 25 milligrams, right? So this is the
Mhm.
concentration. Then you divide this, right? Because we need to figure out how many mils you need.
Mhm.
Take divided by 2.5 milligrams, right?
Mhm.
So you take 25 milligrams divided by 2.5 milligrams. And that should equal then 10 mils. Yeah.
Oh, okay.
So I only say that because what if this was something that was like 77 milligrams? Then you won't be able to, figure that out as easily. But I tried to give you an easy one.
And then that actually ties back into my earlier question for like the derm issues. So that's the actual brand name.
The
actually, no,
generic name for it, yeah.
the generic name of what owners could go find.
Yes. And it's important for you guys to know the generic and brand names for all your drugs.
Mhm.
So
Yeah. And then for that, so like the 25 mgs, is that like, so let's say an owner goes and buy Benadryl and they don't really know what the dosage would be. Would you just go like off the 2.5?
So technically speaking, are we allowed to prescribe medications to owners?
No, we're not allowed to.
Okay.
But like, let's say the owner's freaking out, and they look it up, because I imagine that's something they
And they look it up, then that's on them, right?
Okay.
Like, absolutely. Now, it's an over-the-counter medication, so like
Mhm.
that's like a little bit on the gray end of things, right?
Mhm.
Like it's gray. And Benadryl's like fairly safe, but there's always side effects, right? Like for anything. So, but technically,
we can't prescribe.
we're not prescribing. Now, if you have protocols within your hospital that like your doctor has already like written out, this is like if somebody calls and says my animal's having an allergic reaction or whatever and whatever, and they say this is the dosing that we recommend, so you're taking those phone calls in your hospital, okay? That is different, that you can, per hospital protocol, that you can do. But if you're outside of work hours, that is
not work.
Entirely different. So,
okay. I'm speaking hypothetically. I'm not saying that's something I've done before, but I'm just asking for generally.
Right. Like technically, we're not really allowed to do that. Now, I mean, sure, like if I'm at home with my own animals and my animal's having an allergic reaction, am I going to be like, oh, I can't dose my own animal with Benadryl because I don't know the dose? No, I'm going to give them Benadryl. I don't care. So, or do I not look it up in Plum? I absolutely do. So, or for other drugs too. No, I look it up in Plum. I don't care. Okay. Anything else, guys? I know Melody keep us on here all night.
I'm
so-
pretty good for now. I'll
right.
stop talking so that other people can ask questions if they do have questions.
I'm like, we've been on here before with Melody for like 6 hours, so I'm not kidding. We did have one. It was like literally 6 hours. Great. So, awesome. You guys did great today. We got a lot done. My favorite emergency as usual. So,
Let's have good discussions.
yeah. So perfect. So yeah, let's continue doing what you guys are doing. You're doing fantastic. Make sure you guys take some time for yourself again this week. Okay. Enjoy just a little bit of time. Don't study too much, so that way you can actually retain stuff, because if you study too much, it just becomes a blur. It really does. So, and then, yeah, we'll meet again next week. So, and then just take down any questions that you have. So, that way you can cut off Melody. No, just kidding.
Yeah. No, I'm just asking questions because nobody has have questions. I'm like, maybe other people have the same questions.
Absolutely. I'm just joking with you. I'm just joking.
I know.
I'm joshing you. No. Perfect, guys. Great. Well, I hope you guys have a great day. It's rainy here, so I hope it's sunny wherever you are.
Yes, it is sunny.
And yeah, enjoy the rest of your day, and I will talk to you guys soon.
All right. Thank you, Beth.
Bye. Take care, guys.
Thank you.
Of course.